Hi everyone, we're going to talk about ear disorders today. Hearing screenings is the biggest thing that we can do for newborns on helping to detect any hearing issues. There is a joint committee on hearing for infants. Also, this is supported by the U.S. Preventative Services Task Force and the National Institute of Deafness and Other Communication Disorders. So if you have a little one with an abnormal hearing screen at newborn status, then that needs to be reassessed at 3 months. And it is known that detection and treatment of hearing loss at birth has been shown to save over $400,000 in special education and cost by the time the child enters school. So to complete hearing screenings in newborns, we're typically taken care of in the nursery. We're looking for evoking and autoacoustic emissions testing, and this is going to cause a response, an auditory response in the brainstem. All states have newborn screening programs. There is an Early Hearing Detection and Intervention Act of 2010 that mandates statewide screenings for newborns. The American Academy of Pediatricians, in their Bright Futures program, also recommends pure tone audiometry at the ages of 3, 4, 5, 6, 8, 10, 12, 15, and 18. And then if you have a child that is not meeting your standards, then you can request more frequent monitoring of those children. We're going to quickly review some anatomy and physiology of the ear. We know that with the external ear, it's used to transmit sound waves from the outside to the inner, to inside into the middle ear. Its purpose is to help manage any debris. The tympanic area in the middle ear, it separates the outer and the middle ear. It is that protective barrier. It also contains ossicles which transmit sound waves to the inner ear. Oops, thought I went too far. Our eustachian tube, it helps to allow balance of the middle ear with equalizing air pressure. It also protects from any nasopharyngeal sounds, pressures, or secretions from going in the opposite direction. It drains secretions from the middle ear down into the nasopharynx. So if you have too much fluid in your ears, that eustachian tube works towards getting that down into the nose and the back of the throat. The inner ear, we know, transmits sounds, and it helps in our balance. If you've ever had someone that has had really full ears, whether it's from fluid or infection, sometimes you can see balance issues and they feel a little unsteady. Most ear issues are localized, but they can have some problems that are related to other systemic disorders. We know that ears can be impacted by viruses, bacteria, or fungal infections, having a foreign body in the ear, or any form of trauma. There are also conditions that we'll go into further, that neurological dysfunctions that can impact the ear. If you're having a poor immunological status, that can impact the ear, and then any congenital anomalies. As with any body system, it's important to collect a good history. You're going to ask about that medical history, if they've had any abnormalities, any ear conditions, any dysfunction in the craniofacial area, if the little one had any issues with prematurity, if there's been pain, fever, or any other symptoms such as a recent upper respiratory infection. Does the child have any itching or discharge from the ear, any ringing in the ear? It's important to ask about what environment they're in during the day, whether they're in daycare where they're exposed to more children that may share bacteria, if they're in a noisy environment, if they're exposed to smoke during the day. Also knowing their endocrine status, if they're have any issues with their blood sugar, and also if there's been any familial history of any ear disorders or kidney malformations, because the ear and the kidney develop at approximately the same time during gestation. So during your physical exam, you're going to look at the external structures of the ear. It's important with little ones that they are comfortable, or you feel that they are in a safe place, because they may not be interested in you looking and touching at their ears. So being safely seated on mom's lap or dad's lap, caregiver's lap, is often a good place to start. This is also going to help in assessing for developmental milestones related to hearing and speech. You're going to palpate and you're going to rotate for tenderness and inflammation. You're going to pick up the top of the ear and move it around to see if you can elicit any tenderness. In doing an otoscopic exam, you're looking at the tympanic membrane. You're looking at the bony processes, the cone of light, any air fluid level, any bubbles. You're going to note for retractions or any bulging, perforation, or any redness to that area. And the tympanic membrane, if you're doing a pneumatic otoscopy, you want to assess what that motility is, and and with that test, you could also test for acoustic reflectometry. So some common diagnostic testing that you might do is the evoked otoacoustic emission test, the auditory brainstem response, some audiometry, pneumatic otoscopy, tympanometry, acoustic reflectometry, tympanocentesis, and then if you are noticing issues, some laboratory test or even genetic testing. We won't get into the specific details of each of these diagnostic tests, but it can be found in your book on page 738. One of the most common things that you're going to see in practice with pediatric patients is otitis media, and the American Academy of Pediatrics has some evidence-based guidelines available for diagnosis and treatment of this condition. So the most important thing is making that accurate diagnosis. When did the pain start? Is there a middle ear effusion? Can it be confirmed with pneumatic otoscopy or a tympanogram? Are there any signs of middle ear inflammation? And there can be that excess fluid that is causing pressure in the ear that can cause pain. Using antipyretics or analgesics to help with that pain is advisable. AAP is encouraging you to do initial observation versus antibiotics if you should come across the little one that has the reddened ear or is looking as they're in pain, and then have the parent follow up with you again to make you aware of how that ear is doing and how the child is feeling. And then if symptoms have worsened and the child is not improving, then antibiotics can be ordered. So continuing with those practice guidelines by the AAP, making the right choice for antibiotics is important. It is recommended to start with amoxicillin or augmentin. Depending on the age of the child, discuss preventative measures to help the child not to develop an ear infection. These measures would include making sure the child is not exposed to passive smoke. Breastfeeding is known to help with ear infections in the first 6 months of life. If the baby is on a bottle, to avoid bottle propping and avoiding any or trying to minimize any exposure to other children that have any other minor acute illnesses. Other preventative medicine measures, include getting the annual flu vaccine for children 6 months and older, and then making sure that children are up to date on all their vaccines, including the pneumococcal vaccine, once the child for kids younger than 2. If despite all of these measures and the child has a recurrence of the ear infection several times, then a referral is indicated. The referral depends on the age, the severity, and the response to the treatment. Infants and toddlers should be seen again if there hasn't been complete resolution of the symptoms associated with the ear infection, and an ENT referral should be initiated for any unusual conditions, if there's congenital malformations, cranial facial abnormalities, or a failure to respond to treatment for otitis media. You would also consider referring to an audiologist if the ear has had issues for a prolonged period of time, such as infection, and you're concerned about hearing. Let's talk a little bit about tubes in the ears, also referred to as pressure equalizing tubes. Clinical guidelines recommend referrals to ENT for tubes only if the child has had recurrent otitis media 3 times in 6 months or 4 times in 1 year, with at least one of those episodes in the last 6 months. If a child has craniofacial abnormalities, they may be needing tubes. Tubes are placed under general anesthesia, and it's a relatively quick process, takes about 15 minutes, and then the child recovers and are usually able to go in a very quick period of time out of the recovery room. There's no precautions when bathing, showering, or doing any surface swimming. If the child is going to be underneath the water or diving, then earplugs will be used. Once the tubes are in place, if there is an early onset of otitis media without any drainage, most children are able to fight this off on their own. Okay, let's talk about some specific ear problems in children. Otitis externa, so that's in the canal, not in the middle ear, behind the eardrum, and it is a diffuse inflammation of the external ear, and it may involve the pinna and the tympanic membrane. A simple infection, you may see redness, some swelling, some discharge. You can have some small abscesses of the hair follicles in the ear. You can also have impetigo, a superficial infection in the epidermis. Otitis externa can be classified as a mycotic otitis externa, which is caused by a fungal infection, or can also be a chronic external otitis. These issues can extend past what we typically see in healthy kids if there is an immunocompromised patient or someone with diabetes. So one of the purposes of the ear canal is also to protect, we know, the inner ear, but that protective barrier in that ear canal has been damaged. It's most frequently caused by excess moisture that has stayed in that ear canal. It usually becomes an acidic environment, and that needs to be changed back to a neutral or basic environment. We see otitis externa in kids that swim. It's often called swimmer's ear, but the chlorine will kill the normal ear flora, and it can allow pathogens to grow in that area. We also know that the buildup of wax is protective to the ear, and regular cleaning can remove that barrier, which takes away that protection as well. And then soap, local trauma, sweating, allergies, or stress can attribute to otitis externa. We know that it can be caused by Staph aureus or Pseudomonas. They're the most common, but it may be multiple bacteria noted. There is also a condition called otomycosis, which is caused by Aspergillus or Candida, and this can be as the result of systemic or topical antibiotics or steroids to the area. It's common in kids with diabetes. Clinical findings that you will see with otitis externa: you may have itching or irritation, pain that's disproportionate to what's seen when you look in the ear, pressure or fullness. It's rare to see systemic complaints. You may see some hearing loss or have some otorrhea. You can have some swelling in the periauricular area, and then also possibly some lymphadenopathy in the pre and post-auricular area. On physical exam, the child may have pain if you move the tragus or the pinna, or you make any attempts to look in the ear with an otoscope. You may see a swollen ear canal with debris in it. You may see drainage, as we talked about, the lymphadenopathy. You may see some red crusty pustules. Itching can be associated with a thick, dark gray-green drainage that may be coming from the ear. You can also see a dry appearing canal and atrophy as the result of chronic otitis externa. And then there may be the presence of ear tubes, or you may even note a perforation of the tympanic membrane. Diagnostic testing is not typically needed with this condition unless there's no improvement seen, and then you might need to do a culture. Some differential diagnoses include acute otitis media with perforation, TTO, which is tympanostomy tube otorrhea, meaning that the child already has tubes in place. They've developed an upper respiratory infection, and now you're having drainage coming from the tubes. Suppurative otitis media, necrotizing otitis externa, cholesteatoma, mastoiditis. We could have lymphadenopathy as a differential diagnosis, a dental infection, or eczema. So management of otitis externa, eardrops are the key component, and those may be with acetic acid or an antibiotic drop, with or without a corticosteroid drop, considering what the ear looks like. You need to avoid ototoxic drops if there's a risk of perforation. Systemic antibiotics are not needed unless it's a severe infection. It's important to educate your patient on the use of drops. If there is significant swelling, then wicking may be needed, and encourage the child and parents to avoid cleaning or manipulating the ears in any way, and to prevent swimming at this time, and then of course to use analgesia for pain management. Treatment may also include debridement with a Q-tip. You may need to clean out the ear canal with an antiseptic solution if there's concerns for impetigo, and then apply an antibiotic ointment. And then fungal infections need to be treated with an antifungal, or such as clotrimazole or miconazole, or something like nystatin. Some complications that you can have is infection to the surrounding tissues if impetigo is seen, irritated infections of those hair follicles, and then you may see some malignant otitis externa if you have progression or necrosis of the tissue. With it, otitis externa prevention is important, so try to avoid water in the ear canals. With swimming, having some well-fitting earplugs. You can make a home concoction of alcohol, vinegar, and distilled water to make an otic mix, a 2 to 1 to 1, and apply 3 to 5 drops daily, especially after the child has been swimming, and that's going to help to dry out the ear canal. Sometimes using a blow dryer on a cool or warm setting can help dry out that ear canal and keep the moisture away. And it's important to encourage the child not to scratch the eardrum or put anything in there that they might be using to clean, and then to avoid any use of agents that might take out earwax, as this is a protective mechanism to the ear canal. Okay, let's talk about a forearm body in the ear canal. It's usually placed by a child or another child. It can be toys, it could be cereal, it could be an insect, it could be plant materials. When trying to assess what's going on, it's important to take a good history report of anything purposely been put in the ear, any itching, buzzing, or fullness to the ear, any cough or hiccups, any one-sided pain or drainage. So when you go in to look at this ear, you may be able to see the foreign body. Management of it, you need to have good visualization most importantly, you need to have a cooperative patient, and you need to feel comfortable in this skill set. If it's something that you don't feel comfortable in, then it's important to refer them to somebody who does. And it's important that you have the proper equipment, so that if there is something there that you need to extract, you can safely. With the newer batteries that are out, these can be very small and may have been placed in the ear. If you find a battery that's been put in the ear, that needs to be removed emergently. So spherical objects are the most difficult to get out. If you have noticed a bug in the ear and it's still alive, it's important to try to suffocate it with mineral oil, and then if you're not able to know that you can get it out, refer for removal, and then irrigate the ear only if the tympanic membrane is intact. So if you're not for sure, then don't irrigate. Complications of a foreign body may include infection, perforation of the tympanic membrane, or damage to the ossicles. And prevention is the most important thing, to educate children and parents not to put, as the saying goes, anything bigger than their elbow in the ear. Okay, we're going to close out this video, and then we will come back and start talking on our next section, which is otitis media.